I would request you to kindly address the speakers and request them to speak over this interesting topic for today's session.
Thank you, Shikta. If at the outset, I welcome all the delegates to this module of Pulmocon. I've tried to keep this module a little different because I feel that some areas are not very often touched upon, like urticaria, which is quite difficult at times, which teaches a doctor a lot. The patients are not cured and they move from one doctor to another. And we are not usually not in a discussion or in meetings regarding urticaria. That is relatively less frequently found in the agenda of the meeting. So I thought that's a very important issue we should talk. The second one is asthma with loss of reversibility. This is a very, very important area because it mimics COPD. And we do not know whether many of our non-smoker COPD are actually asthmatics. So the third topic is in echo. So with this brief introduction, I will introduce my first speaker, Dr. Shoibal Moitra. Shoibal is one of our junior colleagues. He's practicing in Kolkata. I'm actually doing proxy for Dr. Mahesh today. And Shoibal is a highly academic person because only recently he has completed his PhD. Despite being in a very busy practice, he could manage to do it. And he did his PhD on asthma and allergy itself. His overall experience is 23 years in the practice with 19 years of experience as a consultant. And he has got multiple publications, more than 30 odd publications in renowned peer-reviewed national and international journals. He has authored chapters in books also. He's a member of several societies and currently is associated with the Apollo Gleneagles Hospital, Kolkata. So without any delay, may I request Dr. Shoibal Moitra to take his issue on and deliver on his topic. Shoibal, please. Is there an issue? Kaushik? Kaushik, it is not opening?
No, sir, we are sharing the screen, sir.
Okay.
All of us. And we would be able to meet in person again in the next Pulmocon 2020. So my presentation today is how to approach a patient of an urticaria and what are the ways in which I go about, or rather we go about, according to what the guidelines and the evidence say. Because we all know that urticaria is a common and very distressing condition which affects the quality of life for all the patients, so which needs to be adequately addressed too. So by definition, it is a common dermatologic condition that typically presents with intensely pruritic, is very much itchy, highly itchy. That is the most distressing symptom the patient comes up with. Well circumscribed raised wheals, which range from several millimeters to several centimeters or larger in size. They can occur with angioedema. Angioedema is a localized non-pitting edema of the subcutaneous interstitial tissue, which may be painful and warm. So it could be a benign self-limiting disease, or it could be a symptom which can indicate an underlying disease, and at times it could be life-threatening, like leading to anaphylaxis. So there are several subtypes of classification. So one is a spontaneous urticaria. That means urticaria where no actually any trigger or any causative factor could be found out. This is the most common type, which we most commonly see, which is nowadays known as a chronic, or nowadays known as autoallergic urticaria. It could be an acute spontaneous type. Acute, when there's a wheals and angioedema occurs less than 6 weeks, and chronic when it's more than 6 weeks. Apart from that, there are physical urticarias. There are many physical urticaria. That means some physical irritant is causing the symptoms, which could be something elicited by cold, some by pressure, some by localized heat exposure, or by the sunlight, maybe by mechanical or shearing forces or vibration, for example, jackhammer, or which could be received by water, like bathing in cold water, and increase the core body temperature, like in exercise, or in contact with some triggering thing, any triggering substance contact with that, or can be by physical exercise. So all these things can elicit the symptoms of urticaria in a particular patient, and which comes under a group for the physical urticaria. And they have several names like cold, delayed pressure, heat contacts for urticaria, and so on and so forth. So we need to take a very meticulous history to find out whether the patient is having any of these is urticaria. Because physical urticaria only needs the assurance and the symptomatic treatment, and these are self-limiting diseases. They goes off on their own. So when we look at the differential diagnosis for urticaria according to Yaki, Gallen, and ADF guideline, we must always see whether the angioedema is there or not. That is a non-pitting edematous lesions, which comes and goes on its own. So if they are there, and then we say whether wheals are pitting edemas. So wheals and angioedemas are non-pitting edemas, and there are no wheals and there's no urticarial or itchy rash, then definitely we have to think of that whether the patient is having a hereditary or an acquired angioedemas. And that is a separate group of diseases which are more serious than usual urticarias. And if the wheals are there, and the wheals is, we'll see whether wheals are persisting, a particular wheel is persisting for more than 24 hours or not. Because if it is persisting for more than 24 hours, it goes into the category of the vasculitis. So then we have to do a skin biopsy and see what is the lesion. Along with that, we might need to do an immunohistochemistry also. If the wheals are not, particular wheel is not persisting for more than 24 hours, and then we see whether symptoms are less than 6 weeks or more than 6 weeks. For the more than 6 weeks, it could be present continuously, or it could be relapsing remitting type of the disease. So if it is not less than 6 weeks, then obviously it's acute urticarias. If it's more than 6 weeks, then definitely the chronic urticaria. Then we ask all the questions to rule out the physical urticarias to come down to a diagnosis of the chronic spontaneous urticaria. So this is how we go about the same thing, which has been shown in this flow chart. Now, the detailed history is very, very important once the patient comes to us. When you have a diagnosed patient with a chronic spontaneous or chronic autoallergic urticaria, then we need to do some of the blood tests to rule out what can be the cause-positive factors. For that, we need to see a complete and differential count, and depending upon the history, we need to rule out any infectious diseases, mostly viral infectious diseases. Allergy, a specific subtype, patients gives a history of the patients have taken some food items, and this is coming up. It could be a food allergy associated with that, but only a small subgroup. Majority of the patients won't have any of these histories. So it is a futile to put these patients on a battery of these allergy tests, so which is of no help in evaluating these patients. Definitely, we need to look for the autoantibodies. And autologous serum skin test is a very important test, which is being done in very few centers. So we do it in our department. So this is a very important test, and which helps to know that whether the patient has autoantibodies. And autologous serum skin test, if it is positive, it diagnoses a condition known as chronic autoimmune urticaria, which has a specific treatment. Vesicle activation test is not done in most of the centers. Definitely, we have to look for the thyroid status, and we need to see for the thyroid antibodies, which could be the thyroglobulin, which could be the antimicrosomal antibodies, or the TPO antibodies. Then there is a tryptase is done only when there is associated there is an anaphylaxis, because then we need to look out for any underlying mastocytosis which these patients might have. And if the tryptase level is quite high and it remains high even 24 hours after the patient has an attack of these wheals, ills, and maybe associated with the shortness of breath or choking sensation, definitely, then we have to evaluate the patient for a mastocytosis. And I have said skin biopsy is only if we're suspecting the arterial vasculitis. So we need to see that how much the patient is suffering. That is a very important parameter when we're dealing with these patients. We have taken the history and we have tried to ascertain what can be the cause. In most of the cases, we do not find the cause, but then we need to see how much the patient is suffering, because that is an important parameter which needs to be controlled. That is the itching parameter. For this, we have this articular activity score, or we call it UAS. And for this, there's a scoring system, and depending upon the hives and the pruritus, maximum score being 6 and minimum score being 0. This is when the patient comes and you take a articular activity score, you put the patient on the medicine, then you see whether the US score is reducing or not, because that decides whether you will actually reduce the medicines or you will actually increase the medicines. I'll come about how do we go about in the line of management of these patients. And if this articular activity score is taken up for a period of 7 days, we call it UAS7. That is a means a better scoring than only a single scoring system, because it gives a cumulative scoring of the patient suffering over a period of time. So this is a UAS7, that is the articular activity score for 7 consecutive days. It could be 0 if there is a patient totally asymptomatic in the past 1 week, and it could be highest could be 42 when there is severe chronic spontaneous urticaria. And this is how we go about in well controlled, the mild, moderate, and the severe chronic spontaneous urticaria, because this level of control is very important in understanding how the patients are faring while they are on the treatment. Okay. So what are the treatment we usually give? First of all, we need to know what is the goal of the treatment. Goal of the treatment is to treat the urticaria until the patient enters the remission phase. Remission phase, that means the patient should be asymptomatic, patient's quality sleep should not be disturbed, patient daily activity should not be disturbed. That we call it a well-controlled urticaria. So therapeutic approaches involve several aspects, like first identification and elimination of underlying causes when possible is very, very important, because when the patients come, the detailed history will say that what is the patient's underlying cause which is triggering this. Because if we can find out any underlying cause, it goes a big way in actually controlling the patient's symptoms and achieving a well-controlled disease. And we can eliminate those triggering factors, which could be pollens, which could be dusts, which could be some food items, or which could be some infections, which could be any other things that we need to know. And induction tolerance in induced urticaria when possible. This is for the physical urticaria. And then comes the pharmacological agents in the prevention of degranulation, release of mast cells, mediators, and the effects. And the treatment should always hold the basic principle of treating as much as necessary and as little as possible, because all these drugs carries its side effects. So we need to treat as much as necessary and as little as possible. That is the lowest possible dose of the medicine which is needed to achieve the control in these patients is very important to understand. So we step up. Initially, when we start with a particular first step treatment, and then we step up according to the control of the disease. There are some general principles when we go about teaching, when we go about teaching the patients and also treating the patients. What are these? This is the sum of the things we should be avoided in case of the urticaria patients, and therefore they're actually same for the adults and children. And mainstays we avoid the triggering factors. Always recommended that they should avoid some medicines like aspirin, then alcohol, then NSAIDs. Avoiding wearing tight clothing, because this may worsen the symptoms which is there. Okay, so when there's a treatment algorithm for the chronic urticaria according to the 2018 international guideline. So now the first line treatment is to start with the second generation antihistamines. First generation antihistamines, they are gone away from the treatment because of their intolerant side effects. Then the second comes increasing the dose up to 4-fold, which is very important. This is the second step. then Omalizumab, then cyclosporine, and the other therapy in treatment of the chronic urticaria. So this is the IACI and WHO international guideline, and also the American Academy and American College guidelines. First and the foremost is the avoiding the triggering factors is always it starts with the treatment. It is not the pharmacotherapy. It's first. The first is always we start with try to find out whether it's triggering factors and we avoid those triggering factors. Then we start with the second generation antihistamines monotherapy. We don't give the multiple antihistamines, but with the monotherapy. If the patient is not controlled, we have to look for the control for the 2 to 4 week, that is UA7 score. Okay, it has to come into the well control. If it is not achieving well controlled in the 2 to 4 weeks time, then we increase the second generation antihistamines 4 times the dose. We don't usually in the recent guideline, they are not telling to increase the dose slowly, but they are telling to directly increase to 4 times because this will help to achieve the maximum control, which is very much necessary for this patient because also suffering. They're suffering a lot. Their sleeps are disturbed. That is very important. This is the second line of treatment. But there are other options also, like along with that, we can add another second generation antihistamines. We can add an H2 antagonist, like ranitidine or the famotidine. We can add a leukotriene antagonist, or we can add a first generation antihistamines only at the bedtime along with the second generation antihistamines to give the patient a good sleep during the night. Again, we see for the control for the next 2 to 4 weeks. If the control is not adequately achieved, the next is to add Omalizumab. So the third line treatment now to come up is the Omalizumab. And there is another option for American Academy that to increase the potent antihistamine dose like the hydroxyzine or doxepin. This is according to the American Academy guidelines. But the WHO says second and third line is the add Omalizumab. Still not controlled within 6 months. Very Omalizumab is given for 6 months to see for the control. Then we go on to the fourth line treatment, which is the cyclosporine. In American Academy, it could be the Omalizumab or cyclosporine or any other anti-inflammatory agents like the dapsone, sulfasalazine, hydroxychloroquine, or colchicine, or some immunosuppressant medicines like the tacrolimus, mycophenolate mofetil, sirolimus, cyclophosphamide, or methotrexate. And lastly comes some biologicals like in very recalcitrant and urticarias, intravenous immunoglobulins or the anti-TNF or the anti-CD20. Some of the drugs are still in the experimental stage. But by and large, is the start with the first avoid triggering factors, start with the second generation antihistamine monotherapy, increase up to 4-fold, or add Omalizumab, or add cyclosporine, or some other agents. Most difficult is when the triggering factors can't be identified avoidance, then mainly we have to depend upon the pharmacotherapy according to the guidelines that I have just narrated. How do we treat acute urticaria? For acute urticaria, skin testing or immunoassays to identify specific trigger for acute urticaria and antiedema can be helpful. But allergic cause is also by history. Why? Because the patient might have some other allergic disease. There might be a family history of the allergy, which we call atopy. Then only we can embark on a limited skin test or specific IgE test on these patients. If the history says so, and then we compare the patient's symptoms to understand whether there are any triggering factors which are sensitization matches with the triggering factors, so that we can come down to one or two which can be avoided. So skin biopsy is not indicated in acute urticaria, but only if it is articular rashes persisting for more than 24 hours, which can indicate vasculitis, we go in for a skin biopsy. So most common cause of acute urticaria angioedema include medications and food. So drug history is very, very important. We should always take the drug history acute urticarias. It's a very important. Drugs and food, the most important cause of the acute urticaria, and they should be identified by detailed history and eliminated if possible. So usually in the chronic urticaria, we have seen in that the first line treatment in the chronic urticaria is the oral histamines, which are the key drugs in the treatment of chronic urticaria. And the second generation, like the cetirizine, fexofenadine, loratadine, avastin, levocetirizine, desloratadine, upadacitin, epinastin, and bilastine. These are all the second generation antihistamines which could be used. They have the comparable efficacies. And according to the Articular International Guideline, A second line of treatment, use of fourfold dose of second-generation antihistamines indicated whenever licensed dose fails to control the disease. So this is what is known, but we must always look out for the side effect when we're using this dose in the patients. So the third line has come up with Omalizumab because it became a prominent third line agent in the chronic urticaria. And because of the better efficacy, cyclosporine and omalizumab have been favored over and all, because now we have the omalizumab, which is the main drug, and it has been proven efficacy. And dosage is, we know, 300 milligram every 4 weeks. That's a monthly dose given for a six consecutive months. In the fourth line, we have the cyclosporine, and the cyclosporine, and it is given in severe disease with persistent progression with treatment failure to previous measures. Cyclosporine therapy is an option to refractory chronic spontaneous urticaria. And cyclosporine, along with that, the cyclosporine, we can have the other anti-inflammatory drugs like the dapsone, colchicine, and Montelukast. Montelukast shows a good response in 20-30% of patients who do not respond to therapy with antihistamines. But dapsone and colchicine, definitely they are better preferred in these patients than the Montelukast. And lastly, we have this immunosuppressant medications, which can be methotrexate, sulfasalazine, mycophenolate mofetil, azathioprine, cyclophosphamide, and tacrolimus. There are no control studies available to it. So what we do is that only the patients are not controlled by the previous medication, we usually go in for this line of treatment. There's a miscellaneous which we kept in mind, but so far means actually I in my practice have not been needed to use this, the UVA and UVB or the PUVA. These are the adjuvant treatment given for refractory urticaria areas. But nowadays, with the advent of the newer second-generation antihistamines and the omalizumab, majority of the patients can be controlled in the first line and the second line treatment, and few patients might need a cyclosporine therapy. So what we see that when we are approaching a patient of the urticaria, first we need to find out what are the triggering factors, which is very important because that will decide that whether the patient has to avoid some agents or not. And after we know the triggering factors, we have controlled that, then we start the pharmacotherapy according to the guideline given by Yaki, Gallen, WAO, or the American Academy and the American College. And initially, we need to first look out that whether they have stated angioedema or not, and whether there is arterial vasculitis. So after ruling out arterial vasculitis, the angioedema, then the chronic urticaria, we have to rule out the physical urticarias. And then in the chronic spontaneous and the chronic autoallergic urticaria, while doing a workup of the blood test, which includes the complete count, which can include liver function test, the thyroid autoantibodies, the ANA, the patients needs to be started. We need to find out all the triggering factors, avoided, and started on the pharmacotherapy, and evaluate the patient every 2 to 4 weeks to see whether the control is achieved or not. And this treatment is usually controlled. It usually controls the disease, and that has to be continued for around 4 to 5 months to 6 months, or maybe one year in some very refractory cases, which can help to achieve the disease control and reduce the disease activity in the patient. It's not that the patient symptoms are over, we stop the medicines. It's not like that. We go from a stepwise approach, and then we again come down stepwisely in these patients. Thank you very much for the patient here.
Thank you, Dr. Moitra, for beautiful elaboration of chronic urticaria and urticaria as a whole. I would like to know from you certain small things, but before that, I wish to open it to the audience for questioning. Shikta, would you look for the questions being placed? And we may have Dr. Prasannan also in the course of discussion. Shikta, any questions? Before she speaks out the questions, let me ask Dr. Moitra, why steroid has been dropped from the list of medications? Usually, in all such immunological problem, we have steroid, maybe at times as cornerstone of treatment. But here I find that you directly jump from antihistaminics to omalizumab.
Yes. Actually, first of all, really, I would like to thank Dr. Bhattacharya and Pulmocon for allowing me to present my deliberation. The question is quite valid that initially it was that the steroid was quite it was used quite often in the treatment of the urticarias. But slowly then it has been known for two things. One is the steroid use is only there in cases of some acute urticarias only for a short duration of time. And it has been seen that these are all actually inflammatory conditions which need a long-term treatment. The treatment is usually not for like 1 week or 2 weeks, but usually they need a treatment for 2 to 4 months. So giving a steroid for the 2 to 4 months actually to associate with lots of side effects. And these side effects where it was mainly seen that these side effects were one of the main reasons why the patients actually had to be taken off the treatment. That is one thing. And second thing is that the patient's main distressing symptoms is the itching or the pruritus. Yes, and that's why that is the main condition which affected the quality of life of these patients. And steroids, though being an anti-inflammatory agent, they are not antipruritic. So what happened is that even with the steroids, as the patient's pruritus were not adequately controlled, so the patients, there was always a tendency of the patients being overusing the steroid, taking a higher doses of steroid to achieve an antipruritic effect, which is usually not seen with these agents. So it was associated with lots of more high side effects, with patient dissatisfaction, with a less control of the patient's symptoms, and thus it was associated with a poor quality of life in these patients. So in all the recent guidelines, the steroid has been dropped out from the treatment guidelines of this is condition, and it was seen with these newer drugs along with the newer second generation antihistamines and these biologicals like Omalizumab, they achieve a better control of the disease and a better control of the symptoms than steroids. Similarly, cyclosporine, which has come up, which is usually those for whom the Omalizumab is inaccessible or cannot be given for side effects. Cyclosporine has come because of its anti-interleukin 2 action, so which helps in reducing the conditions of this patient. So that way, steroids has gone out of in the guidelines, and only place of steroids is there for the in acute urticarias for a short duration of time, and when to achieve a better control over a short duration of time only it is being used. Otherwise, it is dropped from the treatment guidelines.
Thank you very much. The message is that steroid should not be given long term. It should be given only short term for the acute urticaria patients.
Yes,
There are two
yes.
questions. One from Dr. Arun Chakravarti. He wants to know what's the role of type 2 diabetes mellitus in urticaria. And the other question is from Dr. Proshun Chatterjee. He comments whether it is better to start a combination of leukotriene and antihistaminics from the beginning, or to start with purely a second generation antihistaminic, then add leukotriene onto it, or
Yes.
like that.
Yes. So the second question first, that is the Montelukast. So there are only few randomized controlled trials which have shown that the Montelukast is of importance in treating the chronic urticarias, and more so, this Montelukast has a better effect when it is given, say, for example, for the drug NSAID-induced urticarias, specific group NSAID-induced urticarias, shellfish-induced urticarias. Only in this group, the Montelukast has a better effect. Otherwise, it was shown in the larger randomized controlled trial RCTs have proven that the newer second generation antihistamines, they are the better drug, and this drug only in the monotherapy helps to achieve the control in the majority of the patient if they're given properly and if the patients are adequately walked up. So this Montelukast has only become an add-on drug which can be given only in the second line and not started in the first line treatment. So it has come up only an add-on drug. Only if you are finding this patient is NSAID-induced urticarias, they can be given as an add-on drug from the initial step. Otherwise, mostly it goes back. It is in the later in the treatment and guidelines. The second thing is that the diabetes. Diabetics are usually, they're always associated with the pruritic skin conditions, because what happens is that in the diabetics there are many skin changes which takes place. There's another similar skin condition, allergic skin condition, atopic dermatitis. Atopic dermatitis has been shown to be associated more with the diabetics rather than the urticarias. So if you're dealing with a patient of the urticarias, so the majority of the studies, they have shown There is atopic dermatitis and the infectious skin conditions, which are more important in case of the diabetics. But always it is there that in any kind of this is urticaria patients, in the evaluation of when we do the workup of these patients, the routine blood tests are done to see the better control of the diabetes is needed, because that will help to achieve a better control of the entire immune system, and the immune tolerance is achieved in a much better way. Otherwise, it's an atopic dermatitis and other eczematous infectious skin condition which are associated more with the diabetes rather than the chronic urticaria or the acute urticarias.
Is there any role of anxiety state in urticaria? Because there is one comment that a patient with anxiety had recurrent acute urticaria that subsided on treatment with anxiety.
Yes.
There's a term called neurodermatitis.
Yes. All this whether it's an atopic dermatitis or an acute urticaria or even chronic urticaria, they also comes within the gamut of the psychosomatic skin conditions. So in the psychosomatic skin conditions, what happens is that any underlying urticaria which is there, it can get flared up when there's anxiety or stress. This we see more in atopic dermatitis, also seen in case of the urticarias. Nowadays, this chronic autoallergic urticaria, which is the limb or spontaneous urticaria, the flare-ups has been seen to be occurring in case of stressful conditions. So there definitely the various the transcendental meditations and other relaxation techniques have been shown to achieve a better control of the disease. But these are only adjunctive therapies. The mainstay always remains the finding of triggering factors and the pharmacotherapy. So this is an adjunctive part which has to be addressed to while we are seeing the patients of this condition.
Thank you. There are two more questions, very short questions. Is there any role of serum Ig in estimation in evaluating urticaria, and how long one should use antihistaminics?
First of all, there is no role of estimation of the total serum IgE. That is a very clear message which I want to give with my lecture, because the total serum IgE is a very non-specific test, and it can be raised in multiple conditions. And moreover, in the chronic urticaria, I have said that the allergy is only a small subset, and there the skin prick test or specific IgEs according to the history is a better test, and it is done in only a small subgroup, but not total serum IgE, which has no role in evaluating the chronic urticaria. Number one. And number two is that how long the antihistamine should be used. It is always there. First, we put the patient on an antihistamine. The patient has to be evaluated every 2 to 4 weeks to see that what is the response of the patient, and accordingly the dose needs to be up to titrated. If the patient is well controlled, say 2 to 4 weeks of the treatment is usually continued for another 4 weeks or maybe 6 weeks, and up to the patient condition, depending upon the conditions, continued for 3 to 4 months before we embark on and when the triggering factors have been identified, they have been controlled, and then we decide on lowering the doses. Not before that, because loading the doses early would always result in the flare up of the reactions, and which would definitely not be a very well controlled disease in the patients per se. So it has to be a chronic treatment every 2 to 4 weeks. The patient has to be evaluated, and then depending upon that, at least the minimum 3 months of treatment for the chronic urticarias, that the antihistamine should be discontinued. For the acute urticaria, the treatment is usually short, usually 1 week to 10 days in acute urticarias, and these are mostly self-limiting diseases.
Question for a short answer is how to treat patients with chronic physical urticaria and persistent peripheral eosinophilia.
Chronic physical urticaria, which we also call it chronic inducible urticaria. Chronic inducible urticaria, definitely these are self-limiting diseases, and these chronic inducible urticarias, they are not very much well controlled by the pharmacotherapy. One main important is the reassurance of the patient, but these patients are always put on the antihistamines because these are the major drugs, and that is the symptom control, and they're highly potent antihistamines can be given, along with there has been some role of the use of the mast cell stabilizers, because the mast cells have still been known to be highly active in this group of patients, and the mast cell degranulation, it causes the symptoms in this patient, and the mast cell degranulation occurs by trigger, which is a physical factor. So mainly, basically, it is the antihistamines with or without a mast cell stabilizers, reassuring the patient, avoidance of the physical factor which is causing this is urticaria, that is a chronic inducible urticaria. That is one thing. Second is that if there is persistent peripheral eosinophilia, number one, chronic inducible urticaria, if there's a persistent peripheral eosinophilia, always means there is, along with the chronic inducible urticaria, can co-occur with other forms of the urticaria also. And definitely in this patient, there can be an chronic urticaria with an allergic diathesis with the peripheral eosinophilia or other causes of the peripheral eosinophilia leading to the allergic skin conditions. Of them, atopic dermatitis is very important because at times it's very difficult to distinguish atopic dermatitis from the urticaria. So by and large, chronic inducible urticaria, physical urticaria does not cause the eosinophilia. If there is a eosinophilia, then one definitely has to look into the parasitic infestations or the allergic skin conditions, or maybe related to some drug allergies also. Because some drug allergies can cause a continuous persistent peripheral eosinophilia, which has to be looked into in this patient.
Sir, I think there is another question for you.
Yeah.
And
Yes.
that is a role of famotidine and how it acts.
Famotidine is actually an H2 antagonist. So as I was showing in the flow chart, in what option do we have while the patient is not adequately controlled by the second generation antihistamines. There we can either increase it to fourfold, or we can add an H2 antagonist. So actually this is because they are all antihistamines, and they basically act by potentiating or by complementing the histamine blockage. So it is both we are doing an H1 blockade with the H1 antihistamines. We are doing an H2 blockade with a famotidine or the ranitidine, or we use some drug which has both the H1 and the H2 blockade properties, like this doxepin. So this is only we are adding the histamine blockage where we're making the mast cells, because this H2 blockade also results in the less degranulation of the mast cells. So along with that H1 blockade, only we can give the H2 blockade, so the famotidine role comes into that in that regard.
Thank you, Dr. Moitra, for your wonderful discourse. People are still possibly itching with questions at Articaria itches. We have to go to the next talk. The next talk is as important and as interesting as this previous one. That is approach to asthma with loss of reversibility. And to cater to our demand is Dr. P. Thomas. He is a well-known faculty across the country, a wonderful speaker. So without much more introduction to him, as the slide will speak a lot about him, I just directly welcome Dr. Thomas to deliver his talk.
Am I audible? Is that okay?
Beautiful.
Fine. Thanks, Partha. Thank you for this great opportunity. There are very few people in this world where we cannot say no to, and Partha heads that list. So whatever task he gives you, be it easy, difficult, good, ugly, bad, you jolly well do it. And that's the reason why I'm here. I think it's a great pleasure that he's been persisting with this for the past so many years. And I think it's been a testament of his sincerity and his approach to pulmonology. And that's really what makes him stand apart. And today he's given me, what shall I say, a rather difficult responsibility to try and to talk about something which is always reversible. Asthma always associated with reversibility. And my task would be to look at asthma with loss of reversibility. And I think that's a very, very difficult approach in the sense that to many people, it really may not be the most sensible thing to do, but we will try and see if such an entity exists at all or not. The point to understand here is that this loss of reversibility means that there is a greater amount of asthmatic symptoms, there's a greater amount of dysfunction, there's a greater amount of remodeling, there's a greater amount of airflow limitation, greater amount of exacerbation, greater amount of mortality. This almost fits into this sort of severe asthma group. So we'll try and decipher what severe asthma really is. Yeah, assessing severe asthma and defining this irreversible airflow obstruction, then look at newer therapies and therapies that you can see here. We know that asthma is a syndrome, and I think we've known this for a very long time. It's no longer a single disease. I think it must be absolutely magnificent if it was a simple disease like it was in maybe 1990, 1995, where you said everything was treated with ICS lab and everybody went home very happy. But unfortunately, I think it is not today. We've evolved into phenotypes, and then we've evolved into endotypes. And of course, we have the evolution of this term severe asthma, and it's taken difficult terminologies. And today we have the severe asthma, which is now characterized as a difficult and a different phenotype from the rest of the asthmas that we're looking at. What we need to understand about severe asthma is, again, that severe asthma by itself is not a single disease, but it is probably divided into three stuffs as such. You will have difficult to treat asthma, your problematic severe asthma, and therapy-resistant asthma. Difficult to treat asthma and problematic severe asthma would be asthmas that are not sort of handled very well. They have multiple comorbid conditions which are not treated. There is inhaler compliance, which is extremely poor. So I think all these things put in a box, you can treat these two entities to some extent, whereas therapy-resistant asthma is really looking at resistance to probably the inhaled corticosteroid receptor or whatever. And I think the resistant asthma will really look at that only. The good news is that this is a very small percentage of the population. The bad news is that very small percentage of population accounts for a huge deal of morbidity and mortality, and there's a huge deal of economics and huge deal of logistics that we have in hospital, and we find that they're very, very difficult. I think this is not a very difficult question to answer. It will be all of the above without question. And how severe is severe asthma? And you look at the number of terminologies, and I think that itself will tell you that severe asthma is even more complicated than plain asthma. And that's really what it is. Everybody has his or her own view of what severe asthma is. And I think as you can look out from this, the more papers there are, the more work there is, the more confusion there is, and the more confused we are. So I think that's really what we will require. So if you define severe asthma, guidelines suggesting that high-dose ICS LABA or leukotriene modified theophylline with corticosteroids greater than 50% for the previous year to prevent becoming uncontrolled, which remains uncontrolled in spite of this therapy. So severe asthma is equal to a therapy-resistant asthma. Again, this is not an absolute truth in the sense that severe asthma can be asthma which is non-compliant and non-modified. And I don't think this is a sort of one equal to the two, one equal to the other. It's a question of, I think, trying to find the difference between this. I talked to you about the logistics, and I think this is really what happens. Severe asthma, though a very small percentage, occupies a huge level of asthma healthcare utilization, as seen here. And I think it's important. There are a lot of studies to tell us that. And these are the two things that we will be looking at. Difficult to treat asthma, we've already seen. And then we have seen treatment-resistant asthma, which we shall see over a period of time. This is important. So what do you do when you have severe asthma? You look at all these things, and what do they really tell you? They tell you what you already know, honestly. You know, that this patient probably has a severe asthma, which is not very responsive to treatment, for which treatment modalities are not really working, either because of poor compliance or because of poor selection and poor sort of, what shall I say, individualization of patient treatment, as they call today. We understand that all these things are important, but really not as important as it is. And again, as I said, we are looking at step 4 and step 5. And I think it's very important for us to understand That is, all these elements are used in that situation, be it titropin or Omalizumab, which Sir was talking about. The other things like macrolide antibiotics, I don't honestly think methotrexate and oral antifungals are really on the line. So basically, I think severe asthma is, in my book, the kitchen sink group, where you throw everything at the kitchen sink and think that something is going to work and hope and pray that something works. And that's really what is important. So let's go back to simple asthma and look at simple asthma as a multifactorial disease with genetic factors and environmental factors. And I think this is something that we have known for a very, very long time, that there is a very clear genetic element to this. And there are environmental factors. There is inflammation, there is hyphae responsiveness, airway hyperresponsiveness, and there is reversible airflow obstruction. The classic teaching in asthma is that there is reversible airflow obstruction, but you look down below, this is always not reversible. There are a very clear set of patients with fixed airflow obstruction, and I think we need to really understand and find out what sort of asthmatics have fixed obstruction. And believe me, it is not very easy to demonstrate this. And now that the syndrome of ACO has come in the middle, I think this is just adding to this confusion. But please remember that this is probably a separate phenotype of obstruction, which is fixed. We'll try and see to what extent we can really decipher them. So the severe asthma is not a single phenotype. It is multiple. Early onset, eosinophilic, I think we are very, very, very familiar with that. That's really not the problem. Obese, there is a neutrophilic asthma, which is probably older age asthma. So I think there's a huge level of asthmatics as such, and a huge range of asthmatics that we're looking at today. And it's no longer the simple ICS-LABA disease that we knew some time ago. So we need to look at things like creating awareness, setting up a severe asthma clinic, look at patient education. We need to tell them that these patients, which are probably the slightly older age group patients, though their problem probably starts in childhood, they are a difficult set of patients. If you have a difficult asthma to treat, please tell them, sir, your asthma is difficult to treat, so please make sure that your compliance is good. If your compliance is good, your difficult asthma will become very difficult asthma, and probably severe asthma, and give rise to all the other problems that you are associated with that. So definition of irreversible airflow obstruction in asthma, there is a greater decline in FEV1, and this happens in childhood. And I think that's really what is important. So this irreversible airflow obstruction doesn't sort of jump out of the sky really, but is something that is a progressive problem in childhood. Greater decline in FEV1 associated with moderate to severe asthma is generally never that sort of simple type of ICS-LABA asthma, but it's preferably much severe and probably very severe indeed. Male gender commoner, smoker extremely common. So if you have a smoking asthmatic who keeps coming to you again and again and again, irrespective of the real age group, you look at that. There is overall mortality. Is there a background atopy? There may be a small question mark to that. There is an aspirin sensitivity. There's a wonderful paper from China. I just forgot to get this thing out. It is, I think, from Guangzhou University, which sort of defines this question of IOL in a wonderful manner to try to look at it. So male smoking phenotype, atopy, rhinitis, aspirin sensitivity, atopic dermatitis. And these are the factors that really look at this limit, that very severe flow obstruction that goes progressively over a period of time. It is mildly progressive and it goes on. And this constitutes the bulk of the so-called irreversible asthma obstruction, airflow obstruction that we're looking at. What two things are we really looking at? We're looking at two basic phenotypes. One, of course, is the inflammatory phenotype with which we are extremely common. We know that the inflammatory phenotype is driven by the Th2. It could be Th2 high, it could be Th2 low. We fully understand that there is a paucigranulocytic type as well. Now, we are very, very familiar with the right-hand side of this slide. There's no question about it at all. That's really what we've been banging about for the past so many years, and we have got somewhere with that. But please look at the other side, which is the remodeling. And if you think that severe asthma is equal to remodeling, I think you need to make a small modification in this, in the sense that the clinical phenotype of lung function exacerbations and severity, and finally leading to direction of inflammatory mediators and cell involvement, and smooth muscle inflammatory cells. There is altered goblet cell metaplasia. There are two things here, which is the basement membrane thickness and the ECM deposition, the smooth muscle hypertrophy, and I think this is important. So there are two elements in severe asthma, in any type of asthma, that is important. One is the inflammatory component, which is very nicely reversible, whereas there is a remodeling component that we need to understand. And this remodeling is not something that starts when you're 40 years of age, but it starts when you're very young and keeps slowly progressing over a period of time, which is why I think serial lung functions in these patients, early detection of an inorbitant drop in FEV1, I think is important to look at these things as such. And I think endobronchial biopsies will talk about smooth muscle contraction, smooth muscle hypertrophy is very, very important to know. The smooth muscle, if you take bronchial biopsies, I think it's wonderful to try and pick these things early if you're picked early. And I think if you have this high index of suspicion, please do it. So airway remodeling is looking at inflammation, loss of cartilage, angiogenesis. This is so important today because angiogenesis is a very, very important entity. Goblet cell mucus gland hyperplasia, increased smooth muscle mass. You look at altered epithelium. You're also looking at the meta-analysis of its association with risk and male gender. We talked about male gender. I think it's a meta-analysis which will tell you. This again is a very, very good study. As I told you, this is from China, which talks about the male gender, the predominance of the male gender in these patients. And I think this should sort of, the male gender should alert us to the fact that there are problems here. The asthma risk and smoking as such, association of asthma risk and smoking. There is also the question of association of asthma risk and rhinitis, which is very, very close to the sort of inflammatory type of asthma that you've been looking at. So they may have rhinitis, and this may mislead us to think that we're really looking only at the inflammatory type of the asthma, where there is associated rhinitis and asthma, which is so very common in our day-to-day practice. And we understand today that that could be one of the real issues that you're looking at. There is also this question of asthma risk and atopy for that matter. As Sir said, we were talking about chronic urticaria. Atopy is a very important state which could be characterized by umpteen organ involvements as such, especially the dermatological importance. So we've looked at smoking, we've looked at rhinitis, and we've looked at atopy, and you look at multiple number of studies which will really tell you that there is a population number which is present. This is again, I'm really sorry, I've lost the source of this, but I think it's very, very important to understand there are multiple studies which will tell you from different backgrounds, which will tell you that there is an increased risk and a decreased risk of this problem as such, as we look at this study population. Multiple, absolutely multiple, almost 4 to 5 pages of this, and I think it's very, very important to go through this. Finally, we look at the asthma phenotype and try and see where it fits in. We know the Th2 high and the Th2 low asthma. We really have no real problems with this anymore. We know that they really exist. And we also know that there are multiple clusters if you do a cluster analysis. But how do you treat this type of asthma? You treat this type of irreversible asthma like you treat a regular asthma and look at all the comorbidities that are associated with regular asthma. And when you phenotype asthma, you need to look at this in a holistic sense, in the sense that you're looking at other things, you're looking at an allergic component to begin with. There could be aspirin sensitivity, there could be a cough variant, intrinsic asthma, a lot of things as such. Female obesity, I think, is an extremely important phenotype that you're looking at in this. An infective phenotype that you see in these patients, again, as I said, the severe refractory asthma group 1 and 2, as we look at it, you look at an exacerbation prone asthma. And I think this is again very important. So if you phenotype this will probably fall into one of these 3 things: male, smoking, probably overweight, obese, rhinitis, atopy, urticaria. And you look at the other things here, you're looking at probably a slightly different type of, different phenotype of asthma. Again, we come to this step 4 and step 5, which is important. So looking at the progression of the phenotypes as such, one size fits all is now gone. We understand there are functional inflammatory biomarkers, molecular biomarkers, and predictive biomarkers of response. We have multiple biologic agents, looking at biomarkers like serum IgE, whether it's Omalizumab or Mepolizumab, with which we are very familiar with at this point of time. We'll very shortly be getting Benralizumab and then probably Dupilumab. There are a lot of other things that could really come about, and I think it's important. So it's very important to look at phenotypes, and basically, for even a general practitioner, it's extremely important that you look at an atopic and a non-atopic type of the asthma that you're looking at, whether it is simple asthma or severe asthma. I think it's important to look at. So we've come a very, very long way as far as severe asthma is concerned, and that's what we're really looking at. Omalizumab, if you remember, I think is from 2003. Can you imagine? And I think you're looking at the IL-5 and the other drugs that are there today with the tiotropium and the glycopyrronium and all these things, which probably will get fit into the GINA sometime over the next couple of years. And I think it's important for us to understand. So this, of course, proportion of patients who have allergic asthma, and you look at all the biologics that are really involved in this. You start with the therapies like Dupilumab, looking at Lebrikizumab, and then the other specific Mepolizumab and Benralizumab. Then, of course, you already have the IgE with us. This is a long list. So these patients are treated like normal asthmatic patients. Number one, they probably need high doses of corticosteroids. Number two. Number three is that they are extremely exacerbation prone. They keep coming back to you again and again. They're a very difficult type of asthma to really explain because there are a lot of things about them we don't know, but they are a very, very small population, in the sense that identifying them itself would be a huge challenge. And we clearly need to understand that we need to use all these medications in a very judicious and choice manner to try and look at these. Omalizumab, of course, we know does have a very clear role and does have the FcRI receptors. We know there is a lot of evidence for Omalizumab, inflammation, exacerbations, hospitalization, quality of life, lung function, rescue medication, the Omalizumab trials that you're really looking at. We now look at Mepolizumab, which is IL-5, a key cytokine. But the problem here again would be the eosinophil, with which a lot of people could have a truck with that, whether it's 150 eosinophils, and you say that sputum eosinophil is equal to blood eosinophil. I don't know whether it is relevant for a country like India, or at least super relevant for a country like India. But all the same, I think only time will tell us if we are right or wrong. So we have Mepolizumab, which is again a good drug, an IL-5 inhibitor. Then, as I said, it does produce a reduce in cumulative exacerbations and probably also a significant effect on SCB1. So I think we've looked at a very difficult concept, and we've looked at a very small percentage of the asthmatics, where an index of suspicion, an early index of suspicion, is probably the only trait that will move us into this probable diagnosis that we're looking at, and try and see these patients and select these patients and try and treat them differently, in the sense that you probably use the same type of medication. You can't get medication from the sky to treat them. You know that you have to utilize whatever medication that we have and utilize them sensibly. And I think this is important. But I think the most important thing here is to try and communicate with these people correctly. The smile costs nothing, but it's create much, yet it cannot be begged, borrowed, or stolen, or it's worth nothing to anyone until it's given away. I think this is so important. Do we smile at patients? Many of us don't. We frown at them because the lunch is being delayed or because the work is being delayed. And I think it's very important. I still remember as a child, I used to listen to a radio station called The Voice of America. There used to be a man with a gruff voice who said, if you find somebody without a smile, give him one of yours. I will never forget that. It keeps ringing in my ears every time I see a patient. And I think it's very important, and especially in pandemics like this, a smile costs nothing, but it creates much. There's no question at all. Give your patients a smile, and I think there's nothing like a smile to get through with this. Do we hear patients or listen to them? Again, extremely important. Please look up the difference between hearing and listening. Hearing is when I hear somebody singing in the next room, I need to hear because
yes.
Listening is something that I want to do when I'm listening to you, and you have to tell me what to do. And as I said, thank you for the patient listening. We learn from the past, we live in the present, and we prepare for the future. And I think we very need to clearly understand that the future is going to tell us what to do. And I'll just stop with the words of the great Robert Frost. The woods are lovely, dark and deep, but we have promises to keep, and miles to go before we sleep, and miles to go before we sleep. Thank you very much for the patient listening.
Thank you, Dr. Thomas, for such a wonderful deliberations. I cannot imagine a better person to talk on this topic and overall on asthma. The area is really difficult. We have got few questions. Let me deal with the question first. Before that, I like to introduce our today's chairperson, Dr. P.M. Mahesh, who was busy in some other important issue. He has just joined. Welcome, Mahesh.
Yeah. Thank you, Partha.
Proxy for you so far. So you take over the charge from me.
Good evening, sir. Dr. Thomas here.
Yeah, listen, there are 3 questions. There are some questions. Okay, and Shikta, can you ask the questions to Dr. Thomas?
Yes, sir. There is one question. How to differentiate asthmatic irreversible airflow obstruction from COPD patient?
I think that's a catch question. That's catch 22 for me, as far as I can see, because we can't use reversibility as such. And I think there we need to use things like the presence or absence of ATP and the fact that as to whether you're a smoker or not, number one. Number two is I would use age as a very major criteria in such patients. When they started experiencing their first symptoms for that matter, many COPD patients start with their symptoms at 40, 45 years, whereas these are patients who you think start with symptoms earlier in life. So I think a very good history taking is extremely important. Where you started the wheeze, when you started the wheeze, how severe was the wheeze when it started? Do you have background ATP at all or not? Is there a family history? Is there an occupational exposure? I think these are multiple things that will tell you that they are possibly different. There is no one single test to tell you whether it's the best spirometry in the world. I'm sure it cannot tell you that. So I think we need to put all these things in a box, and this is a Pandora's box diagnosis. I honestly don't think it's a sort of one-way street diagnosis at all.
Dr. Thomas, I was wondering, once we say that asthma with loss of reversibility, then perhaps it brings us to 2 subsets of patient. One subset of patient, as you beautifully elaborated, are the severe asthmatics. And the other subsets are not severe, but still having loss of reversibility. They may be termed as loss of remodeled asthma, or you can say remodeled phenotype, and the other is severe phenotype. This is my, just kind of common sense response. And the mechanism for the 2 must be different. So it is a very intricate and difficult issue to actually differentiate these 2 phenotypes. The people who have been remodeled much to have loss of reversibility, being asthmatics, have been stamped at the early part of the life, and later on they are progressively symptomatic. And that subset may be a little different from those who are really the serious or severe asthma. So what is your take on this thinking of mine?
I think the whole question is that 90% of these patients probably start off as regular asthmatics. They take treatment and probably drop it down the line. And I think we really need to understand that the compliance in some respect or the other could have major impact on them later on in life. We're not quite sure at all, because they don't have this effect of the ICS lasting for a very long time. So you're not very sure about this remodel type and things like that. So I think I would think that these patients need to be monitored very, very carefully. When you start off with a low FEV1 in childhood itself or in your younger age group, I think that's a red flag that sort of waves in front of you. And you need to very clearly understand that this person needs continuous workup, even though he may not be very symptomatic, as you very rightly said. There may not be too many symptoms, but there could be a problem. And I think the problem will be red flagging them at all in the first place, because there are no real concrete parameters to red flag them. But then we should try to make an attempt somewhere down the line. And you're very right. It's a very difficult phenotype to place your finger on.
So
I fully agree. Yeah, I fully agree with the Professor Thomas on that. You can use a skin prick testing to help to determine whether these people are atopic or not. But we have seen COPD patients also being atopic. Now you look at COPD also, they have an acute exacerbation, which is also driven by not neutrophils, but it is driven by the eosinophils. So it is a very, very difficult phenotype. I fully agree with you. Pheno can be used in some, again, we have in COPD, but about 20% of COPD patients also show an elevated pheno. So it is extremely difficult. As you rightly said, it's a very difficult phenotype to.
As you said, every single test has its flip side. There's no question about it at all. And I think we need to understand the flip sides and try and make provisions for that and give the cushion that you need to make a diagnosis here. We are looking at a difficult road. We understand it's very difficult. We don't have definite parameters. So I think an index of suspicion is really what drives you here.
And we should have regular spirometry.
Exactly. I think that's a wonderful suggestion. A regular spirometry in these patients, I think is very, very important. A regular inflammatory asthmatic may not need this sort of regular spirometry. You can go by asking him, are you well, are you not well or not? But people like this, people in whom you red flag them to begin with, do need regular spirometry to try and tell you what their lung function is, because they may not be able to perceive their symptoms.
And all sorts of measures to avoid smoking and inhalation of
exactly.
substances. So it's been
one
wonderful.
of the key points here is a lot of these people are difficult and are severe because they don't avoid the indoor exposures. Like, for example, mosquito coils. We have seen women light a lot of agarbattis. So what this does is this will change their inflammation to neutrophilic inflammation. We have a lot of these people get better once they stop using the mosquito coils, once they stop lighting up these incense sticks or doop sticks in their house. Their asthma becomes much more easier to control. So those are things I think in the history we should really look for and try to avoid.
No, I think if you tell them that these doop sticks and mosquito coils will enable them to get COVID, they will stop, but not asthma. You're more COVID prone if you light these things at home, will clearly mean that they will stop, but then not asthma. Tomorrow we'll see the asthma. The asthma is always treatable.
Good suggestion.
So I think it all depends on our psyche. No, our psyche is so made up that way, and everything depends on that.
Agree.
So I hand over to Mohesh. Please take care of the chair and
sure. Yeah, thank you,
Dr. Prasanna. So thank you, sir, for such a wonderful deliberations. It's been a pleasure, and I hope I will be bothering you time again in future.
Thank you.
Mohesh, please.
Yeah. Yes. The next speaker, can you?
He is Dr. Satish from Bangalore. Can you
from Bangalore?
Yeah.
Yes.
We'll be talking on echo.
Echo. A great pleasure to invite Dr. K. Satish, one of the senior most chest physicians in the state of Karnataka, and a mentor for today's talk. And he's well-rounded and he's an all-rounder, I should say. And his area of interests include asthma, COPD, sarcoidosis, lung fibrosis, TB. But I think he's really made his name in the field of HIV. He is one of the foremost experts in the country in the management of HIV, and has nearly about close to 3 decades of experience in that. And he is one of the first to start HIV treatment in our state. And he is currently associated with the Fortis Hospital, Bangalore. I now invite to deliver his lecture. And a very good evening to you, sir.
Thank you. Good evening. Can you all hear me?
Yes, it's clear. It's clear, yes.
Okay, I'll start sharing the screen.
The upper part of the face was not seen.
Yeah. Now, can you see me?
Well, I can see your screen, but neither slide nor you.
Yeah. Okay. In a minute, I think, once I have screening.
Yeah. Now it's okay. I can see you.
I just. In a minute.
No problem, sir.
Okay. Can you all see me? Can you see my slides?
Yes, yes.
Okay. So thank you, Partha, for giving me an opportunity to speak at a prestigious conference like this. And generally, you have a lot of people coming there and participating, and can't believe when this has gone on for 18 years now. And relentless, your attitude and your approach to educate people, and also to invite somebody like me and others. And thank you very much, and congratulations for you and your team on this excellent approach and this conferences. And during the pandemic, you have continued, you didn't leave it, no gaps at all left. Thank you once again for inviting me to speak on this Pulmocon conference. Thank you, Dr. Mahesh, my dear friend, for introducing me. And thank you. Yes, my HIV work is well known because there were very few people who were touching and treating HIV. And I'm basically trained in pulmonology. And Dr. Thomas, and it's always difficult to follow his talk because he's such an excellent orator and also a philosopher. I've taken down, already clicked few of his last few slides, and not about asthma, about his philosophy of life, and which are so important to follow in our life. Thank you once again. And my topic today is on the ACOS, the asthma COPD overlap syndrome. And there have been, a lot of controversy about this. Nomenclatures have been changing, and recently we heard also in another webinar about, is there anything like this, which exists? So is it a new entity? And I'm going to define and then also have diagnostic approach to chronic airway disease, bronchial asthma or COPD, and take you to syndromic approach of chronic airway obstruction. And of course, there are different phenotypes of COPD or ACOS and bronchial asthma together. And of course, there are some new modalities of treatment and summarize in the last about this. So we all know that bronchial asthma is an overwhelming burden on our resources and system. And this is showing all over the world: mild asthma, moderately severe asthma, and severe asthma. If you see just the last part of this bar diagram, moderate to severe and severe constitute about more than 50% of asthma, which is moderate to severe, and mild is only about 13%. And this is the world map showing where all it is common. So still continues to be poorly controlled asthma. Over 50% of patients have asthma that is not well controlled. In all countries, asthma is under-recognized, under-diagnosed, and naturally under-treated. In fact, last year, Sandeep Salvi and the group came up with a paper showing that, very surprisingly, none of our Indian patients have well-controlled asthma. Very surprising to know, and that keeps us awake and tell us that what we are doing is not a good job. So we have to probably awake and do something about controlling asthma, because many of our patients think that they have well-controlled asthma, and many physicians also think that they have well-controlled asthma, but not so, by the criteria of well-controlled asthma. So let's look at COPD. What is COPD? COPD is again another huge burden on our resources. And if you see the jump way back in 2005 and then projected in 2015, there's significant increase in the incidence of COPD, and it's become now the fourth largest mortality producing or mortality inducing disease in the world, ahead of cardiovascular disease, diabetes, and also cancer. So we have these two diseases, both under the heading of non-communicable diseases in the world. Now, what about this ACOS? Is it a different type of phenotype, or is it a separate clinical entity? This was a study. I think this was a good study. What pulmonologists think about the asthma COPD overlap syndrome, and it's a small one, but a good good study conducted with 26 pulmonologists and mean age of about 50. 13 specialized in asthma and 13 specialized in COPD. Among those, 84% recognized the existence of a combination, ACOS, and stated that a mean of 12.6 of their patients might have this syndrome. We all have, different statistics. We all have different kind. I think about my patients, I think I would say roughly about 15% of them have ACOS. The frequency of ACOS in COPD ranges from 10% to 55% according to the type of population studies and particularly the diagnostic criteria applied. And our chairman, Dr. Mahesh was mentioning about it in his talk. In the epidemiological EPI scan study, 17% of subjects with COPD were classified as ACOS. So roughly, as I said, my own figure is about 15%. 23% of patients with COPD between 50 and 59 years of age could have ACOS. And this value rises to 52% in subjects 70 to 79 years. So there is a jump, almost double, when you take, elderly group of 70 to 79 of patients. So which means that, there is definitely an entity called ACOS, and our approach to ACOS must be seen as a different approach than this. So you have asthma on one hand, a heterogeneous disease. We all know shortness of breath, wheeze, tightness in the chest, and causing variable expiratory airflow obstruction. COPD is common, preventable, treatable, characterized by persistent airflow limitation, usually progressive, associated with chronic inflammatory response in the lungs to noxious particles or gases. Exacerbation comorbidities contribute to the overall severity in these patients. And the combination of these, the COPD, asthma COPD syndrome, characterized by persistent airflow limitation with several features usually associated with asthma and several features usually associated with COPD. So ACOS is defined by the features that it shares with both asthma and COPD, a combination of these. The syndromic diagnosis of asthma, COPD, and ACOS in an adult patient, given the extent of overlap between features of asthma and features of COPD, the approach proposed focuses on features that are most helpful in distinguishing asthma and COPD. So features that we come to some basic features that favor asthma or COPD. and which is important. For example, especially in a pandemic where we just have to listen to the patient as Dr. Thomas put it, and because we don't have spirometry, we don't have any other ways of objectively measuring and marking them as asthma or COPD. So what favors asthma? Onset before the age of 20. What favors COPD? Onset after the age of 40. So if you have a patient who's sitting in front of you with age of 40 years, and there are other patterns of respiratory symptoms, very important. Variation of symptoms over minutes, hours, or days is asthma. Persistent of symptom despite treatment. Patients continue to have symptoms despite treatment. Persistence is the word here. Symptoms worse during night or early morning. In COPD, good and bad days, but always daily symptoms and exertional breathlessness. This will never go in patients with COPD. Of course, I'm talking about moderate to severe COPD. They can also have symptoms worsen at night or early morning, but predominantly they're exertional breathlessness. They are symptomatic throughout. There's no worsening during change of season or seasonal variation. Symptoms triggered by exercise favors asthma. Emotions, laughter, dust mite exposure, or any other allergens. And in COPD, chronic cough, sputum, preceded onset of dyspnea and unrelated to triggers. There are no triggers in COPD. Lung function, if it was a pre-COVID era, we would record a variable airflow limitation, either using spirometry or peak flow meter. One can have a normal spirometry, and one can come with very severe, airway obstruction. In COPD, there is a persistent airflow limitation, FE1 of FEC ratio 0.7. Lung function between symptoms in asthma, normal. Lung function abnormal between symptoms. They can be completely in normal in terms of their own symptoms, but the lung functions are always abnormal. Past history or family history helps in asthma, and in COPD there may not be any of these history, but there can be an heavy exposure to risk factors like tobacco smoke, for example, biomass fuels, for example. And time course, again, very important. No worsening of symptoms over time. Symptoms vary either seasonally or from year to year. Symptoms slowly progressing or worsening over course of years. In asthma, may improve spontaneously or have an immediate response to bronchodilator or ICS over weeks. And in COPD, rapid acting bronchodilator treatment provides only limited relief. Chest X-ray may help, can be normal always normal in asthma, whereas severe hyperinflation seen in COPD. So we have this combination. So even during the pandemic, where we have no objective measures, one can really diagnose asthma and COPD by listening to the patient, by going through some basics. What I told you is all very basics, which all of us know about it in pulmonology. So here is bronchitis, asthma overlap, and emphysema showing, ACOS. What is ACOS? So syndromic approach of ACOS is, how do I look at my patients? Is step one, diagnose chronic airway disease. Is there a chronic airway disease? Do symptoms suggest that there is a chronic airway disease? If it is yes, then step two is syndromic diagnosis in adults. Assemble all the features of asthma and COPD to the best described by the patient, and compare number of features in favor of each diagnosis and select a diagnosis, which I already mentioned. And if the symptoms do not suggest it's a chronic airway disease, then consider other diseases as first, and then think about this. Coming to the risk factors, as Dr. Thomas put it, about gender, age, BMI, smoking, allergies, acute exacerbations, the phenotype of exacerbation. All these are important. So history taking it becomes a very important part of the diagnosis of asthma, COPD complex, and ACOS. Smoking exposure, infection, genetic susceptibility, and so on. And if you have an obstructive airway disease, take it as asthma. If all these criteria which I mentioned, are fitted into that, take it as COPD plus or minus emphysema. If the syndromic approach of history taking and simple objective measurement and an X-ray shows that it is COPD. And if there are combinations of these two, there are overlap of these two, is called asthma COPD overlap syndrome. So it's said, is it a novel clinical phenotype or a genotype? And then the known treatments of asthma, we all know about, the ICS, LABA/LAMA, corticosteroids, leukotriene receptor antagonists, and Thomas was mentioning about all those, unpronounceable MAPs, Omalizumab, Benralizumab, Mepolizumab, Lecudrizumab, and so on. And they have an important role in asthma management, especially severe asthma or refractory asthma, and they respond to biologicals. And others which are there, including thermoplasty in patients who have non-eosinophilic, non-Th2 asthma. Whereas in COPD, ICS, LABA, LAMA, and there are, of course, corticosteroids, theophylline. Then there is oxygen, pulmonary rehab, and also this LVRS, which is used for a very specific type of COPD, especially the upper lobe emphysema and so on. So on one hand, we have an asthma treatment which is different. On the other hand, COPD treatment is different. So how do we combine in patients with asthma COPD complex? So if you see the combinations here, and you have smooth muscle dysfunction, and you have small airway inflammation, and leading to bronchoconstriction, hyperresponsive state, and hypertrophy of the smooth muscle and inflammatory mediator release. And small airway inflammation, there is mucosal edema, there is mediator release, and there is, of course, epithelial damage and mucus secretion, leading to ACOS, leading to frequent exacerbation and poor quality of life. And whenever we assess patients and what is the goals of treatment, the goals of treatment in any of these is, number one, to improve quality of life. Number two is to preserve lung function, especially in asthma. And number three, most important, is to prevent exacerbations of asthma or COPD. So phenotypic approach to ACOS, definition of ACOS by spirometric criteria. So we have spirometric criteria. And what are the spirometric criteria? Spirometric criteria for asthma, at least one, which is positive for bronchodilator response, a FE1 of more than 12%, and more than 200 ml from baseline, 10 to 15 minutes after 200 to 500 micrograms of albuterol or any equivalent, we use salbutamol. Positive for provocation test, the methacholine challenge, which is not done on a regular basis, or a histamine challenge test. And then a spirometric criteria for COPD, which is post bronchodilator FE and FEC ratio of less than 0.7. This definition has no consideration for clinical characteristics leading to high implications of a false type. So phenotypes of ACOS, there are different phenotypes of ACOS. A large number of patients with obstructive disease, from those with predominant asthma features, to those with predominant COPD features can be considered to have ACOS by these criteria. An asthma predominant feature, a COPD predominant features is what we say. So let's examine the phenotype 1 of ACOS. This is allergic asthma predominant phenotype, a history of childhood asthma, allergic rhinitis, or urticaria. The patients have eosinophilic lung inflammation or bronchial inflammation, and history of smoking usually not present. This is asthma predominant phenotype A. Phenotype B is features of severe non-eosinophilic asthma, which Thomas was dealing with. No history of smoking. However, their lung function is poor and they exhibit fixed airway obstruction. So a fixed airway obstruction, non-eosinophilic asthma, and no history of smoking. Patients with severe asthma have a poorer prognosis and higher risk of COPD in later life than do patients with non-severe asthma. Now let's examine phenotype C of ACOS. Patients have features of both asthma and COPD. Patients have history of asthma when young. They also have an allergic lung inflammation and a history of other allergic disorders, and they have history of smoking. I think this is the commonest that we all see phenotype C. History of smoking, history of asthma in the past and when they were young. This is the phenotype C. Now phenotype D, patients have relatively pure COPD. They do not have history of asthma or other allergic diseases. They do have a history of smoking, and their clinical manifestations are highly compatible with COPD. But some patients with COPD have bronchodilator reversibility. So they have some bronchodilator reversal. That's phenotype D. So what about biomarker approach to ACOS? So this is done, for example, sputum eosinophils. And this study published in European Respiratory Journal showed non-smokers, healthy smokers, asthma only, COPD only, and ACOS. If you see here, the combinations that, here there is eosinophilia in the sputum in patients with ACOS more than asthma only or COPD only. But this is not what we do in our daily routine practice. And we take the blood eosinophil as a surrogate marker of sputum eosinophils. So what about management strategies for newly diagnosed ACOS? So we have, asthma predominant, COPD predominant. So in asthma predominant, we have ICS and LABA, and plus or minus LAMA, plus or minus leukotriene receptor antagonist, and consider macrolide if patient is non-eosinophilic. If it is eosinophilic, we have ICS, LABA, LAMA, leukotriene receptors, and consider anti-IgE, which Dr. Thomas was mentioning, like Omalizumab and other biologicals like Mepolizumab, Benralizumab, and Dupilizumab. COPD predominant, these are LABA-LAMAs, ICS and LABA, plus LABA, ICS, LABA, and LAMA, and PDE4, inhibitors. Consider macrolide here, like azithromycin, for frequent exacerbators. And of course, in those who have other like eosinophil, then ICS and LABA, plus or minus LAMA, can be used in these patients and managed together. So what about exacerbations? These exacerbations are common. They frequently exacerbate. And, I've already mentioned about how to treat COPD and when should we suspect and treat it, and similarly asthma. So there are criteria for asthma COPD overlap syndrome. If you see the right side of my slide, two main criteria or one main and two additional criteria. So main criteria are, which I've already mentioned, significant bronchodilator response, FEV1 of more than 12% and more than 200, and here it's more than 200. This is significant bronchodilator response. Sputum eosinophilia are elevated more than 50 ppb of exhaled nitric oxide, which many may not have, but if you have that, that will help. And previous asthma symptoms starting at the age of less than 40 years. The additional criteria are: number one, elevated total IgE; number two, atopic status; and repeated significant bronchodilatory response of FEN more than 12% or more than 200 ml, and peak flow follow-up of typical to asthma. Now, if it is overlap and more than 2 exacerbations or one leading to hospitalization during the last 1 year or so, or FEV1 less than 50 predicted, and this overlap has low exacerbation risk or a high exacerbation. You can further phenotype this and say low exacerbation risk or a high exacerbation risk. And similarly, asthma COPD overlap syndrome is to be treated. So then it becomes easy for us, once we know that how to treat asthma predominant phenotype and COPD predominant phenotype. And again, you also have this low exacerbation risk either in asthma or COPD or in ACOS itself, and then high exacerbation risk. Those who have high exacerbation risk, ACOS, for example, is a combination treatment of COPD and asthma guidelines. But notice that both diseases generally medication includes at least the following, which is ICS and LABA, or ICS, LABA, and LAMA. So which is, a common sense here, because it's a combination of diseases. Here there is nothing like using only LABA or LABA and LAMA alone, because these are patients who have an overlap and require definitely an ICS. And high exacerbation patients, of course, require the ICS. And there have been studies about roflumilast and other macrolides. So referral for specialized investigation if necessary. Patients with persistent symptoms, exacerbation despite treatment, diagnosis uncertain, and alternate diagnosis, bronchiectasis, for example, post-TB tuberculosis, scarring, pulmonary fibrosis, pulmonary hypertension, cardiovascular, and the others need to be excluded. And of course, LAMAs in uncontrolled airways disease, we know we have been using LAMAs for some time now, and especially severe refractory asthma often requires consideration for phenotypic factors that should be recognized and properly treated. LAMAs in uncontrolled obstructive airway disease, now part of our armamentarium, and where we use in uncontrolled severe airway disease, whether it is COPD or in asthma, more so in COPD. And these are some of the studies of tiotropium in poorly controlled asthma used, and I've been part of one of the global study on tiotropium used in patients with, especially with severe asthma. And LAMAs, of course, naturally becomes part of the ACOS and the ACOS COPD phenotype, and to be used in patients who respond to to LAMAs like ACOS, for example. So in summary, distinguishing asthma from COPD can be problematic, particularly in smokers and older adults, as I showed that the ACOS numbers increase with the population that we study, like 70 to 79 years. The number of patients, the percentage goes up to double. ACOS is identified by the features that it shares with both asthma and COPD. So for that, we should know what really constitute asthma, what really constitute COPD to put together in the basket of ACOs. A stepwise approach to diagnosis is advised, comprising recognition of the presence of chronic airway disease and the syndromic characterization, which I showed and mentioned, as asthma, as COPD, or overlap between asthma and COPD as ACOs, and confirmation by spirometry, and if necessary, these patients must be referred to specialized investigation and so on. These patients have higher mortality. These patients have higher exacerbation. These patients utilize our resources directly and indirectly, and that is why this type of phenotype must be recognized and must be given importance as as a separate phenotype entity as ACOs. Thank you so much for patient listening and for giving me an opportunity to share my thought, how I deal with ACOs in this Pulmocon 2020. Thank you. Thank you, everyone. And questions?
So we have a few questions for you.
Yeah.
The first question goes, sometimes CCF mimics COPD with overlapping syndrome. Is it true?
Sometimes?
CCF
mimics. Okay. CCF, that's why I said, it's also important to recognize and treat these patients with ruling out various forms of treatment, various forms of investigations, and cardiovascular system or cardiovascular diseases are one of the important factors in COPD because of the smoking risk. But they don't mimic as such. One can easily distinguish a congestive cardiac failure patient from asthma or COPD. Definitely we can, but there can be a coexistence of a cardiovascular problem like a CCF in asthma, in elderly asthma especially, and in patients with COPD. Of course, cardiovascular problems are more common in patients with COPD. That's why there's been a recognition of using in COPD beta blockers, for example, aspirin, for example, to prevent cardiovascular mortality and morbidity. So definitely we have to keep in mind it's in elderly geriatric population who come with airway disease and also have CCF, but one can definitely distinguish between these by using echo, for example, and other clinical criteria which will help us in distinguishing this.
Sir, we have another few questions for you. Number one is, what is the difference between asthma with loss of reversibility and echo? Are they same?
Okay, this is one type of an entity which I showed where, an asthma, there is no history of smoking here. And these are, non-eosinophilic. And I think Dr. Thomas was mentioning about it and he spoke about irreversibility. These don't reverse with bronchodilator like FE1 of more than 12% or 200 ml to a 200 to 500 milligrams, micrograms of salbutamol. And these come under a separate type of phenotype of ACOs. There is no history of smoking here. So these are fixed airway obstruction. These are difficult to treat asthma. These are non-eosinophilic asthma, and they also have frequent exacerbation. This is a separate type of phenotype of ACOs, where there's no history of noxious, triggerers like smoking or a biofuel, exposure in these patients. These are definitely another, phenotype.
And sir, is there any difference in the quality of life in asthma, echo, and COPD?
Good question. As I mentioned, the goals of treatment of any airway disease is, number one, quality of life. I look at quality of life, number one. Number two, preserve lung function. And number three, exacerbations. Very important. If somebody like an asthma, for example, is having frequent exacerbation, poor quality of life, unable to do routine works, frequently getting admitted to the hospital, and with optimal treatment, and patients adhere to the treatment, then of course you look at biologicals, and there is different. COPD, quality of life, generally, if it is severe, is poor quality of life. That can be improved by pulmonary rehabilitation, oxygen therapy, nutrition, and so on, and that will help. And ACOs, which is a combination of these two, can exaggerate the poor quality of life. If somebody has very severe ACOs, their quality of life is poor. But there are methods, there are definitely intervention which can improve. Even, for example, very severe COPD with upper lobe emphysema, where valves can be put, aggressive treatment like LVRS can be done. So all these treatments are available to improve a quality of life of these patients.
So I think, sir, these are all the questions which we had for you in today's session.
I think there is one more question there. Any role of imaging in ACOS?
Yeah.
And
so imaging in ACOS will reflect, as I said, mostly of COPD, hyperinflation. There can be some, bronchiectasis and emphysema and those things. Then in an asthma, as you know, in an asthma, imaging does not reveal anything, especially if you are doing about chest X-ray. If you are doing, of course, a CT scan in ACOS, if it is COPD predominant, then definitely you will find, some changes of COPD because it's a predominant phenotype of ACOS.
There are two more questions.
Yeah.
One is there any role of roflumilast in echo patients?
Okay. If it is frequent exacerbation, exacerbator, and COPD predominant, then you use roflumilast. And as you know, roflumilast has shown, to prevent exacerbation. It also reduces indirectly, weight. Many patients feel that, they've lost some weight, but, tolerating the dose is very important. Initially, you have to warn this patient, start with a small dose, and then increase if patient is tolerating. And many of them do, tolerate if you explain to them and use it properly. And I always remember one of my patients, who used roflumilast for frequent exacerbation and lost significant weight. And he came back with his friend and saying, he's an obese patient. Can you give this, treatment to him? Can you use this roflumilast? He didn't have COPD. I said, no, we can't use this. This is not a obesity drug or an anti-obesity drug. So this sometimes, help. And the roflumilast has a role in ACOS of a COPD predominant frequent exacerbator.
Someone has confusion about differentiating asthmatic with irreversible airflow obstruction from COPD. You have already touched the issue. Would you like to say a few more things?
Yeah, I think we all have this problem. I keep it very simple, Dr. Partha. One, if there is history of smoking, I'd say, this is COPD. And if there is no history of smoking, in an asthma. And in asthma, reversible and irreversible. And Th2 driven, eosinophilic, non-eosinophilic. These have helped me to solve this, problem of, I won't mention them as COPD, because if you start saying non-smokers as COPD because of the irreversible obstruction, your treatment has to be completely different. So I would say here, irreversible, non-eosinophilic, asthma than is COPD. Otherwise, you will start doing, various treatment for COPD, which is not, required, and they don't respond.
Sir, in this context, I have one question. Nowadays, we are learning about the term called non-smoker COPD, and this is a new phenotype. So if you come across non-smoker COPD, what shall we say? Like, they have features of ACO also, like they have overlapping features. What can we tell, that they are non-smoker COPD or they are ACO patients? What should we tell them?
Yeah, and it's a very good question. Very good question. I'm glad you brought it up. Yes, we have non-smoker COPD, where, for example, exposed to high biomass fuel or noxious stimulants, either in a factory or and then various places where they're exposed. That's a non-smoker type of COPD. So you mentioned clearly non-smoker. Then it becomes completely different, including, for example, tuberculosis. Again, a non-smoker, COPD. We don't call it as COPD in these patients. Of course, you have to use a different term. Tuberculosis, induced obstructive airway disease, TOPD, and so on and so forth. So you mark it as something which is non-smoking, and what does it, if you know, then it becomes easy. For example, tuberculosis, non-smoking COPD, tuberculosis reason. Non-smoking COPD induced by asbestos, silicosis, biomass fuel, and so on. So then it becomes, easy to treat them and also identify them as a different kind of phenotype. You make your own kind of this, but make it very clear that these are not asthma patients. These are, non-smoking COPD patients.
Yes. Are there any more questions?
No, sir. I think we have covered all the questions as of today.
Thank you.
Okay, if there are no more questions, I'd like to thank Satish for an excellent talk on ACO, and especially after different phenotypes and the possible managements for different phenotypes. I think that's a very beautiful talk on ACO, and I would like to close this session. Partha?
Thank you.
পার্থ স্যার একটু আনমিউট করে নিন।
I'm sorry, we have got a very good program on next Sunday at 6:30. That is on eosinophilic lung disease.
Okay.
3 topics, one on general eosinophilia and